The following is a paid program. Advice and opinions expressed during the program are solely that of SSM Health, not WBEV or Good Karma Brands.
And welcome into Taking Care of Business. I'm Justin the Ninja Wilski here, sitting down once again with Dr. Bert Callahan with SSM Health. Dr. Bert, it's always a pleasure having you on. You always bring me the coolest stuff to look at. So if you're not watching on Daily Dodge TV, highly recommend you do so. You'll also be able to watch this back on Daily Dodge TV if you happen to be listening on the radio and want to tune back in. And when you're there, we do welcome you to go ahead and like the video, subscribe to Daily Dodge, and click that bell to get notified when we have videos like this, because they are incredibly informative. And I always think it's better to be informed than uninformed, especially with everything going on in the world right now. But we're going to focus this right down into the really cool specific thing that you do. Let's first remind everybody, Dr. Bert, for anyone who doesn't know who you are, talk about your relationship to the Dodge County area.
Yeah, thanks, Justin. It's great to be here again. My name is Bert Callahan. I'm an orthopedic surgeon. Came to Beaver Dam in 1996. Came out of the Army and set up practice, and I've been practicing in this area since that time, doing general orthopedics. So I'm currently primarily work at the Waupun Hospital. I have some clinic in Beaver Dam here at the SSM building, and getting it's been 28 years, getting at the tail end of my time here. People ask a lot these days, especially as I'm getting older. And so my current plan, just for anyone listening, is I'm going to retire at the end of 2026. So 2 years of active orthopedics.
So still plenty of time for you to come on and talk to me and bring
absolutely.
Cool stuff
as often as you'll have me. So
awesome.
I
love it. We do want to remind everybody that they do want to get a hold of you guys. Two phone numbers: Waupun, Beaver Dam, Waupun 920-324-6802, Beaver Dam 920-887-6650. And I think we said that they probably ranked at the same place, but feel free to dial each one.
Yeah, either one's good.
There you go. You also have a great team that you work with. Go ahead and let us know about your team.
Yeah, so I have two physician assistants that I've worked with for a number of years. Luke Lencher, based here in Beaver Dam native. And then Joe Heckenkamp is based primarily in Waupun. And then my colleague, other orthopedic surgeon in Waupun, is Eric Nelson. He sees patients, does the same types of stuff that I do. And then he works a lot with Andrea Smits, who is a nurse practitioner from the Waupun area, and they work together very closely doing orthopedics and surgery and the things that I do as well.
Well, I guess first I want to start off by, I didn't know you were in the Army, so one, thank you for your service.
Thank you.
But doing what you do now, this isn't what you did when you were in the Army, right?
It is. I went in after, they have a program where they will pay for medical school. Medical school is expensive, and so you come out of it and you serve in the Army. And so I did my orthopedic training at an Army hospital in Denver, Fitzsimmons Army Hospital.
Did that include doing a lot of things like knee, shoulder, hip replacements, or is it more like repair, reconstruction?
All of the above. It's an orthopedic surgery residency, just like at any civilian residency. University of Colorado was the one in Denver that we do the same thing. It's really in the Army, in that setting, it's just a teaching hospital like UW but everybody has a uniform on.
Wow.
And so but once you get out, then we go out to after I finished that, I went to Alaska to Fort Wainwright in Fairbanks and worked at the Army Hospital, where I primarily did surgery on active duty soldiers. So that setting was a little bit more sports medicine type stuff, ACL reconstruction, shoulder reconstruction, and the like. But
well, we're definitely thankful to have you here in our area, not just for the work that you do, but the knowledge that you bring to it. And today you brought us some really cool stuff. We've talked knee replacements, which I think we said was the number one replacement.
Yes, most common.
And then second most common was hip. We talked about that last time. And now we've moved on to what is the third most common. So we're making our way down the list,
right?
Which is shoulder.
Right.
And I guess it makes sense because I'm thinking about what joints get a lot of work. And I think about myself personally. I'm up and down a lot. I walk a lot, I do all that other stuff. So knees and hips make a lot of sense. Shoulders, I talk a lot with my hands. A lot of people do. We're always moving stuff around. I can understand why that joint would also get worn out much easier.
Right.
Tell me a little bit about, because we talked a little bit beforehand, and you made a comment about rotator cuff versus shoulder replacement. I guess my first question is, what exactly is the rotator cuff? Is that just the socket the ball goes into, or what is that?
Yeah, what that is referring to, and it's rotator cuff, C-U-F-F.
Not cup, C-U-P.
Correct.
Okay.
Which a lot of people, and it sounds similar, I get
Right.
that, but it's a group of muscles that are really critical to the movement of the shoulder. And so they start on the shoulder blade. The shoulder blade has actually 17 muscles attached to it.
Oh,
so
wow.
it really is a very complex orchestra of motion there to all those muscles moving together. But the four most important ones make up the rotator cuff that are then attached to the top of the humeral head. And so any movement where your hand is out away from your body, the cuff is in play. And the farther away the hand gets, the more leverage and strength is required from the cuff. And so when you have a problem with it, those are the movements that tend to really be a problem. You try to reach out. You can carry a 40-pound bag of soft water softener salt into your house, and you can't pick up your coffee cup on the table if the rotator cuff is a problem. And so it's a very common thing to occur just with aging. It's the rotator cuff was shown over 100 years ago to be an area where, as we age, the blood flow starts to diminish, and it's very prone to tearing. And so I say sometimes it is very common for the shoulder to wear out before the rest of us wears out. So very common problem.
Okay, so that makes a lot more sense because you were making you made a comment that the access, the incision, the work that takes to go to do a rotator cuff repair is less than it takes to go in and do a full shoulder replacement if a full shoulder replacement is needed, but the recovery time or the inpatient outpatient status is different.
Yeah, the pain that people
Right.
have afterwards is oddly much less after replacement than it is after rotator cuff repair for most people, and there are fewer restrictions on movement after the replacement because with a rotator cuff repair you have to protect the repair. So any movement with the arm away from the body, I tell people if your elbow's away from the body, you're pulling on the repair. So I just sewed your cuff down to the bone.
Right.
And then the bone and tendon have to mend together. But people can generate plenty of force to pull that tendon through the suture if they're not careful.
Right.
And so anytime your elbow is away from your body without support, your cuff is in play. And so, that's for 6 weeks. And so just picture your day-to-day activities. If you can't raise your arm away from your body,
Right.
life gets complicated.
And when you think about it, all of our joints, a lot of them are just simple machines. It's just it's a lever, it's a ball socket kind of thing. So we may think it's nothing to pick up something, light. This tablet's fairly light, but the leverage, the pressure it's putting
Right.
at that pinpoint, I imagine, that's got to be a lot of force.
Yeah, if you had a rotator cuff tear, you couldn't lift that out there. I mean, it would.
Thank goodness I'm good.
That's right.
I guess I'm going to ask you a question related to that then. Is there stuff, is there stuff we can do to help with maintaining that rotator cuff strength? Should I just walk around like this all the time to keep the strength up, or?
I mean, you can, I suppose, but I think the shoulder is no different than the rest of the musculoskeletal system. It is clearly a use it or lose it proposition, and it becomes more apparent as you age. And so when you're in your teens, your 20s, even 30s, you can really abuse the body, the musculoskeletal system, and get away with it. It changes as you get past 50, and it becomes much more critical if you haven't taking care of your body that well when you're younger to do some strengthening, some stretching, do some regular conditioning activity to help maintain the strength. And for a certain degree, for people, you can't prevent the age-related change that occurs, but tendons respond, and the body itself responds to the force it sees. So if you're doing regular strengthening of the rotator cuff, the tendon will be stronger. It will strengthen itself versus if you're inactive or less active.
Kind of that use it or lose it mentality.
Absolutely.
That definitely makes sense. So I want to ask this. Can you have, I'm assuming this is correct, you can have rotator cuff issues, but your shoulder joint is just fine, or vice versa, or you could have problems with both, right?
Yes.
So we know what's going on rotator cuff. Let's move on to shoulder, because you brought in some really cool stuff I want to dive into, and we know that's what we want to talk about today. Like you said, third most replaced joint in the body. I guess being the third most, how often are we seeing this happen in the United States?
So there are about 100,000 shoulder replacements done every year in the U.S., which is less than knee or hip, but it's projected to increase 2 or 3 times even in the next couple of years. So it's really, and even that's been my experience in practice. When I was starting out, I wasn't doing that many, but it's every year there's more and more and more. And then as we'll talk about the different types of replacement, they've just become more and more common. So every month, I would have to look at the numbers, but there are people. It's not every week, but every month they're doing 2-3 shoulder replacements.
Now let's talk about the cause or the need for shoulder replacement. I know we talked in the past when it came to like knees and hips. That scary word arthritis came up. I'm assuming the same general relation when it comes to shoulders.
Yes. So the shoulder, same way, it's kind of a ball and a socket joint, and the surface of the bone on both, there's a layer of cartilage, and that wearing off of that cartilage that occurs, that's what arthritis is. And so it happens in the shoulder. But like you had said earlier, a lot of people have rotator cuff problems, rotator cuff tears, and don't have arthritis. And so that's a separate category. And then there are people who their rotator cuff is okay, but they don't have cartilage left and they have arthritis. And that's where you get into the replacement end of things. And some have a combination of those, which then leads to the different types of shoulder replacement.
Now, when I think about how our bodies move, I know like our knees really kind of have a limited range of motion. Like they don't bend backwards, thank goodness. Hips, more freedom in movement, but still somewhat limited by the way our bodies are designed. Our shoulders have to be some of the most flexible, positionable, joints that we have.
Right. Those 3 joints are very different. And
Yes.
shoulder has the greatest range of motion at the expense of stability. So for a hip or a knee to be dislocated, that takes a lot of trauma. Like Tua, when he was in college, at the end of his career, he dislocated his hip. Bo Jackson dislocated his hip. Those take a lot of force. Typically for a young person, it's a car accident type force that does that. Shoulder replacement, like Shohei Ohtani, had a partial dislocation of his shoulder sliding into second base. That kind of thing can happen if you get positionally in a bad position. And it also plays into it the person's inherent flexibility, because there's a spectrum of flexibility for all of us.
Right.
And the more flexible you are, the more prone you are to shoulder instability and dislocation.
I'll say, who hasn't seen the classic 80s film where Stallone pops his shoulder out of place and knocks it against the wall to pop it back in place and just keeps going like it's nothing.
Well, he's Stallone. So
yeah, of course. Yeah, we'll give Sly a pass on that one. Talk about the procedure, the work that goes into it. When you're doing your shoulder replacement, is this? Are you having to make a large opening? What are we looking at?
Yeah, it's so the surgery itself takes about an hour and a half, and the incision is on the front, and it's usually 6 inches in the front. You can see the shape of the shoulder. The main shape is the deltoid muscle, and so that's pulled up out of the way, and you kind of go right next to that side of it, and you really drop right into the shoulder at that point. And then when you come down, once you're past that level, you're down on the shoulder joint. One of the rotator cuff muscles that comes across the front, you have to take off of the bone, and then you're in the shoulder joint.
Now, I guess that answers something I didn't even think about, because I guess in my brain I thought you just kind of, and I know it sounds stupid now that I'm saying it, but indiscriminately make a slice until you find the shoulder. But you are trying to make your way through and move stuff aside. Correct. So that you can get to it without causing any other damage.
Correct.
And stuff.
Yeah, and most people's, there are mild differences that you have to be aware of, but most people's anatomy is the same. Same enough to know what if you don't, you shouldn't be doing it. Right. Surgery is not that hard if you know the anatomy. You know what you're trying to accomplish, and you know the anatomy, you'll stay out of trouble.
That's good to know. I don't know the anatomy, so I'll stay away from the surgery. I want to talk a little bit about the anatomy of a shoulder, and you brought in some parts that are the replacement parts to it. But let's dig in a little bit more. So you've got your socket. That's the part that's attached to like your rib cage and your collarbone, all that across, right?
The socket is the a part of the shoulder blade.
Okay.
So the shoulder blade has no bony attachment to the ribs or the chest wall.
That's right. That's on the back side.
It's on the back side, and it sits on the chest wall.
Okay.
It basically not floats. I mean, it's attached by muscles.
Right.
But the only bony connection of the arms to the trunk is through the collarbone.
Okay.
So that's why if there are traumas and things, it's not uncommon to break the collarbone. But if you see a shoulder blade, it's a little goofy, it's kind of triangular, and then on one end there's this round, flat area, then that's the socket. Very shallow. I mean, it has a slight depression, but it's a very shallow, which allows that range of motion.
Right, and also leads to the easier separation and dislocation.
Right.
And then on the other end, much like we see in a hip joint, you then have the ball that's on the top of
Correct.
the
Humerus.
The humerus. There you go. The funny bone. There you
The
go.
funny, yeah.
So those are the parts that are grinding together when you have the issue or you might need a replacement. And so those are the parts that have had parts made to replace them.
Correct.
You brought a few of those in today, and just like we saw with the knee and just like we saw with the hip, I can see progression through the different parts. Let's talk a little bit about them.
Yes.
So what do you got there?
So the first thing I'll show, this is a humeral component. This is kind of the old model that came out when Dr. Neer in the U.S. in the 1950s, he started doing shoulder replacement. It was much like this shape. And so this goes down into the bone, and then you have a headpiece that fits on here to recreate the shape of the humerus. And then you would have a socket. I don't have an example of a socket piece for this, but you'd have a socket piece to go on.
Right.
And then the rotator cuff is attached over here to the bone on this side. This type of implant is also used in fractures. That's a thing we didn't mention. That's
Right.
where you sometimes do replacement. But these little holes in this component are used if you have these pieces fractured, you can sew them with suture down to this part of the implant and use the holes to put the suture through.
And you said that would be cemented in as well.
Yes.
And that
also.
would eventually let your body kind of heal to and stick to and grow onto.
Right. So in this is generally referred to as an anatomic shoulder replacement because we're replacing the normal anatomy. You're putting a ball on the ball, you're putting a socket on the socket.
Right. Now, when I think about that one and I go back to thinking about the hips that we talked about last time, the hip socket ball was more rounded. I thought of it as a ball. Like I felt like you could almost roll it across the table.
Correct.
This is a little more flat, a little more disc-like, but you said this matches more closely to what we have now.
Right.
Okay. But that's changed? Do we do something different now?
Well, we still have this model, but it's a little different. Now we have an implant like this. It's a little smaller. You can see shape different.
Yeah.
For comparison, that's the hip replacement one.
Right.
But same kind of textured at the top, smooth at the bottom. The bone grows into it. So if we're doing an anatomic shoulder replacement, same thing. We have a piece like this, and it looks like so.
Okay.
And this, you can see the difference in those two in height and.
Yeah, this looks like it's a half ball where that is a little more flattened, mushroom head type.
Right, and both are available. You have different diameters, you have different heights to match what the patient has.
Gotcha.
So you're looking at what you're removing and you're trying to match this size.
And so you're also then having to kind of predict what was there prior to any wear, tear, grinding, worn downness that's there as well, right?
Right, and you can get a pretty good idea with that. I mean, you're cutting that portion off, so you literally have it in your hand and you're matching it, and you're putting it on, so the diameter you can get pretty accurately. You can kind of get an idea of how much is worn away, and then you have a bunch of trial pieces to put in and see how it feels in there.
Now, I know when we talked before about putting some of these units in, we're talking about the hip. I'll use this one as an example. You're like, this part has to kind of get pushed into the bone so it can heal and grab. So there's, talking about the tools of the trade, a little like hammer type thing, whatever you got to do to get that in there. Same thing with a unit like these or that. Yeah, where
Yeah.
you're going to have to insert that into the bone.
What's the number on the top of that one? Do you see?
11 millimeter.
Yeah, so is this one. So these come in, 6 is the smallest. They go up to 17, 18. So there's a lot of different sizes. So people's anatomy is
Right.
different.
Right. Some people are bigger bone than others, right?
Correct.
There you go. But then on the flip side of that, you got to have the socket replacement for it. And I know we've talked about, the advancements in plastics. I think you said it was vitamin E. Mm-hmm. I remember that. Okay. That gets put into the plastic so it can make it wear a little bit slower.
Supposed to improve the wear properties.
Right.
It gives it kind of a yellowish tinge.
Now, let's talk about that replacement. So obviously you said these are very shallow sockets. You're not replacing it with something that's deeper then, because again, you're trying to match what was there.
Correct.
Do you find that after replacement, is there a higher probability of dislocation? Or is it?
No. It's no, they're not at a higher probability because even within the native shoulder, the stability really depends a lot on the soft tissue around it and the muscle tension around it. As long as that is healthy, then that will be stable, and you put them in correctly. In the shoulder, it's very critical that you get the rotationally, you get it put in correctly to match the anatomy. If that's off, that can make it more easily dislocatable.
Now, when I think about the shoulder blade, as you were describing it, my brain was telling me, like, I don't feel like there's a lot of, or at least as I'm visualizing, I don't feel like there's a lot of extra bone material there where that end is for the socket to put something, super long into the bone. So is there a different way of attaching it there?
Yes. It would be helpful if I had an example, but I don't.
Is it in the visual that we have?
It may be, yeah.
Let's go ahead and bring up that visual for people to see. If you're watching Daily Dodge TV, you'll be able to see this. Or if you're watching back on Daily Dodge TV, we have a great visual from Dr. Burt showing the different parts.
So we were talking about the one on the left, the anatomic shoulder replacement. You can see the stem, you can see the ball on the humerus side. Then on the socket side, that white flat thing, there's looks like a keel.
Right.
That's what goes into the bone in that model. There's different things. You can have pegs, you can have keels. There's a metal piece that's textured like it is here that goes in different ways, but that's how you secure it. Sometimes we use screws, depending on if we're doing a reverse shoulder replacement, it's screwed in.
Now, that being said, on that same graphic, you said one's anatomical. What's the other one?
The other one is what's called reverse.
Now, why would you do that?
So the anatomic shoulder replacement depends on a functioning rotator cuff. So you want to put that back up again for a second?
Bring that graphic back up.
So what's not on these images is the rotator cuff. So on the left one, kind of coming through at the top, attaching to the bone at the top on the left side of the humerus, that's where the rotator cuff attaches. If you do not have that style of shoulder replacement will not work right.
Okay.
And so out of that problem came the solution on the right. And you can see basically why it's called a reverse is you put what's labeled glenoid sphere is you put the ball on the socket, and the socket goes where the ball normally goes. So it's a little goofy. When it first came out, I thought that's bizarre. And it started in the 80s in France, but it was approved in the U.S. in 2004.
Okay.
So I finished my residency in 1994. So it was 10 years after I finished my residency. So as far as widespread use through communities like ours, that's been really the last 15 years probably that's been done.
And so really that was kind of an invention based on necessity, because you need to have the ability for the rotator cuff to attach to something, or else you have a perfectly good joint but no ability to really move it around, right? Or really do anything with it.
Right. And the reason is an important function of the rotator cuff is to hold the socket or hold the ball against the socket.
Right.
While the bigger muscles, the deltoid, the pec, the lats and back, they move the arm. So if you think of it as if you had a 2x8 laying out in front of you and you had a rope attached a third of the way down and you wanted to stand up the 2x4, if you just grabbed the rope and pulled, the 2x4 would slide on the ground.
Right.
If you would need to step on the end of it and then pull. So the pull is the deltoid. Your foot on the end of it is the rotator cuff, and so you can you can bring your arm up. So if you don't have a functioning rotator cuff, and you try to do this, it's shoving that head up under the socket.
It's just going to be pushing it up instead of lifting it up.
Right.
Okay.
And so with the reverse shoulder replacement, that the ball on the socket prevents that from happening. So you do not need a rotator cuff at all when you do a reverse.
Oh.
So that's the interesting part of it. When you have a big rotator cuff tear, particularly in an older person, it's not repairable. You can't fix it. And so prior to the reverse, you would try to put an extra large head in to try to leverage off and that just didn't work that well. And so when the reverse came out, it really solves that problem amazingly with a very relatively simple solution. And so you end up with something that looks, then you put the socket on the humeral side, and then you've got a ball on the glenoid side, on the socket side.
Interesting. And I guess maybe, again, a dumb question on this, but do they lose much, if any, of their ability to hold things out? I mean,
surprisingly, not to hold things out.
Right.
You do. Shoulder replacements don't, in most cases, give you normal motion.
Right.
But the vast majority of people do not have normal motion going into it.
Right. So if you got arthritis that bad, you're probably not, doing 18 holes twice a day.
Right.
Anyways.
Right. So it's usually better motion than you had, but it's not normal motion. It's not what the good Lord gave you. I mean, it's not. It should be better than what you have, but it's
right.
But so for some, you need to temper the expectations.
Well, quality of life, I think, is the words we've used before. So we know the technology has improved to help with that particular, the rotator cuff, because we think about replacement, we often think with age. Mm-hmm. So that makes sense. Use of the technology, though, has even adapted to the point where you don't necessarily need to hammer something like this all the way down into the bone.
Right. A few years ago, the company, and this company is Zimmer Biomet, which is a big orthopedic company, but they came out with what's referred to as the stemless shoulder replacement. So in place of this, you now have this, which just goes into the top, and this is just for the anatomic shoulder replacement, not the reverse.
Not the reverse. Okay.
But then this goes in there. And just as for trivia, when this company came out with this, and they're one of the biggest orthopedic companies in that market.
Right.
A patient in Waupun, it was a Beaver Dam patient who I did in Waupun, was the first patient in the state to have this implant.
And so far, so good?
I actually just saw him last week because he's having his other side done this next week, and he said, and not everybody says this, but I'm glad that he did, that he said he doesn't even know it's there. He doesn't even think about it with lifting or with doing things.
Right.
So, he has a particularly good result, but the goal is no pain, decent motion, good strength.
Well, and we've talked before, when it comes to any of these implants, it's really difficult to come up with a new innovation and implement it and then expect that to be the new adopted method immediately, because we don't know what that implant's going to wear like or work or how the body will handle it until it's been in the body for 2 years, 5 years, 10 years, whatever the time frame is that they expect these things to last.
Right.
So that's cool. So now, do you have a preferred installation when it comes to doing the shoulder?
Yeah, that's a good question. I'm glad you asked that, because as I started doing the reverse, initially I was a little hesitant to do the reverse because it was just so different. And then I kept getting patients that came in, because most patients that need shoulder replacement are older, and when they're older, either the rotator cuff is not functioning, or it very likely isn't going to function in the next 5 years. And so I did not like putting an anatomic shoulder replacement in those people, because I thought even if their cuff is okay now, it's what happens 5 years from now. If it tears then, it's not going to function right for them.
Right, because you'll have to do a whole replacement again to fix it, right?
Right. And no one wants, but I think the goal should be to do one operation. If you're going to have an operation, and I think that's what most of us want. If we have an operation, we only want to go there once.
Right.
So once I started doing the reverse, I realized that it's really not a change for me. The operation is the same. I mean, to get into the shoulder is exactly the same for both. It's just putting different pieces in, and when I'm using this, it's the same stem I'm using. It's just different on the socket side. So that made it easy to transition to that. And now I really don't like doing the anatomic replacement for that, for the reason I just mentioned with the cuff, because in an older patient, if I do that, then what happens 5 years when the cuff tears? And the reverses function so well. I really prefer to do that, other than if it's a young, like this gentleman I was talking about, he's a younger patient. And I think in the younger patient that their cuff is good, that's the right, by younger I mean somebody in their 50s that for whatever reason needs a shoulder replacement.
Now, is that something where you set expectations with them and say, like, hey, you're going to need to stay on top of making sure you keep that rotator cuff strong and healthy? And
I try to temper expectations. It's just better to under-promise and over-deliver.
I can understand that. Absolutely. Absolutely.
Yeah, I mean, I want people I want to make sure as well as I can that people have an accurate understanding of what is happening. I don't want them to think, you told me my shoulder would be normal, because that would be, I shouldn't say that or imply that if I do. It should be better for sure. But the reverse works so well, and it's it's a very for most people a very swift and recovery. The pain, people have pain certainly, but it's better than having rotator cuff repair as a comparison, and it just functions well for the vast majority.
That's awesome. Well, as a reminder, everybody, we are talking with Dr. Bert Callahan here, talking from SSM Health, talking about shoulder repair or replacement, which is absolutely fascinating. I guess I want to make a point of mentioning, and we've kind of talked about this a little bit, but you said temper expectations. And I think a lot of times when I talk to people that I've known personally that have had joints replaced, the one thing I hear them say, and I always kind of laugh at it because I'm like, that can't be true. And now I know it's probably not, as they say, oh, this works better than it did when it was my original. And I think people just deal with and have to work through that arthritic pain, the deterioration, the degradation of motion, all of that, to the point where when they do finally get it replaced, in their mind it feels like it's better than new, but that's only because they experienced it getting so bad.
Right. I think that's accurate.
Okay. So we are on the same page there.
I mean, if people tell me that, I'm thrilled. Right. I'm glad. I mean, but there's, people, there's some people that are, the glass is half full, and the people that are glass is half empty. And that comes into recovery, and the optimistic, motivated people are generally have better results.
Right. So. Most of the time, I'm just happy the glass holds water.
Yeah, right.
So
right. Exactly.
That's the important part.
Exactly.
Let's talk about recovery on this and kind of link it to the other two orthopedic surgeries we've talked about. You said that this is generally an outpatient surgery.
Correct.
Which means not a hospital stay, that sort of thing. When it comes to like knees and hips, are those also generally outpatient?
That's a good topic. And
okay.
I have a lot to say about that.
Please do.
So that varies depending on where you go.
Okay.
It's most people, and my current practice is I tell people plan to spend one night. You really don't need to spend more than that in the hospital. But I don't like the idea that places are marketing the same day joint replacement as if it is a higher level of care. It is not a higher level of care. It can certainly be done safely, and during the pandemic era, we were sending a lot of patients home the day of surgery. It can. I'm not saying it can't be done safely. It certainly can be done safely. I just don't think there is any advantage to the patient to do that. And I don't know why we on the medical side would think that patients think that's a higher level of care if they really think about it.
Right.
Other than people will do what we create the expectations. If I tell you this is the way we do it, this is normal, this is what everybody's doing it, you're going to go home the same day. That's the way this interaction works. People will do that, but I don't think that's fair to the patient. It's because even the fact that how people look in the evening and going home at 5 o'clock versus going home at 11 o'clock the next morning, people look a million times better the next morning.
Oh yeah, I imagine.
Right? I mean, to go home and the sun goes down, and then you're at home and you just had surgery, and your family members, what am I going to do to? And it's just, I think, take that stress off people. Let them kind of settle, get oriented, have a night in the hospital, and then work with rehab the next morning,
Right.
and go. And then I'm talking about knee and hip replacement.
Right.
Shoulder replacements are a little different because the pain issue isn't there.
Right.
But even from the standpoint, several times a year, I'll have primarily a man, because as we age, all of us men have to deal with our prostate.
Mm-hmm.
They can't pee, and so if you get after surgery and you can't urinate, you get extraordinarily uncomfortable. If you
Right.
don't get that relieved, you can damage the bladder, and so you don't want to deal with that at home. I mean, at the very least, you've got to come to the ER to get it taken care of, whereas
Right.
that can be addressed quite easily and readily, and before you get into a problem while you're in the hospital.
Right.
A few patients will have trouble getting on top of their pain the night of surgery. You don't want to be at home when that happens.
Right.
So I just think it's, in the larger scope, it is just safer for the patient. Everybody feels better, more confident. The family, the patient feel more confident the next morning.
It does make a lot of sense. I think about probably who I think in my mind is the worst patient ever, and that's my lovely wife. I love her to death, but she always takes me to every visit she goes to for the doctor, regardless of how minor or major it is, because she'll look at them, they'll say stuff, she'll nod her head like she understands, and then she'll leave, and she'll have forgotten every instruction they've given. And so I know if she ever needs a shoulder replacement, hip, whatever, that if it was a same day, well, here's the paperwork, do you understand how you take care of things? Okay, bye, have a great day. She's going to be sitting at home freaking out a couple hours later when maybe the pain starts to set in or the meds start to wear off and she hasn't gotten on top of things and whatever. And then she's going to be freaking out, flying through all the paperwork they gave her, trying to find the instructions for what to do. And it's just going to put her into a panic attack.
Right.
And so you're right. Having that, even an overnight, is just that extra little bit of care. So
Right. That's exactly the scenario. And the whole thing, it's a stressful event for
Right.
people to go through. I mean, for us on the medical side, we do it all the time, so that's normal for us. But as a patient, and I'd be the same way if I'm the patient. I'm not used to being on that side, but that's the stress that I want to relieve from people. Mm-hmm. Just that, and on the provider side, we realize, I sit and talk all day and realize, not sure they're getting that. Mm-hmm. And one of the things that makes me kind of tighten up is when someone says to me, and then you told me, and they're about to quote me, and I'm thinking, most likely they're going to say something that I'm going to say, there's no way that came out of my mouth.
Right.
But I clearly left that impression with them. That's
Right.
and so it's communication is tough. I mean,
You told me I could go mountain climbing 2 days after my shoulder surgery.
right.
Yeah.
Right.
Makes
Well, you're in
total
the
sense.
communication industry. I mean, that's inherent. But I feel sometimes I'm limited to vocabulary to try to describe to people what's coming physically when it's a little different for everybody. And
That's why I love doing this show, because you can use all the medical terms you want, and I am going to come back at you with the most dumbed down way to say it, because that's how I communicate. So,
that's where
coming together nicely.
Well, I think that's the way most of us communicate in that setting. But it's so we tend to provide written stuff. We say things over. I don't mind repeating things because I realize it's a lot to take in.
As we're getting down to the final minutes here, I wanted to ask, we know after getting a hip replacement, after getting a knee replacement, there's going to be some sort of physical therapy, because that is a load-bearing, ambulatory, movement-based joint that we use on a regular basis. When it comes to the shoulder, is there physical therapy that's needed, or is it something where you just throw it in a sling and say don't use it for a little while, or?
No, it's definitely physical therapy. It's probably more The knee and the shoulder, it is probably more important to have the therapy. The hip, a lot of surgeons, and it's been shown, you don't necessarily have to do formal therapy with the hip. I don't like that approach personally, but the shoulder, absolutely critical, because the shoulder, more than the knee and hip, has a propensity to get stiff. So in the patient I was talking about earlier, where you do rotator cuff repair and you have to protect the activities, if you sit it in a sling for 6 weeks and so you're thinking you're protecting the repair, your shoulder is going to be stuck. You're going to develop what's called a frozen shoulder. So the shoulder is a very strong propensity especially with a trauma on it, like a surgery, to get stiff. And so you have to move it, but in a protected way, depending on what the surgery was.
And luckily, because you're not indiscriminately cutting up the muscles to get to it, that stuff's all intact.
Right.
So you shouldn't have to worry about re-strengthening a muscle or waiting for a muscle to heal or anything like that. It's just that attachment point and that work that you had to do there.
Right. The one exception in the shoulder is that muscle when you're coming into the shoulder that comes across the front,
right,
that we take off. We most of the time are able to repair that back down. And so that's the limit, is rotation. Just to not, rotating out your hand out to the sides stretches that repair. So I limit people for 6 weeks on rotation in most cases, but up in front, I want them doing that to recover motion.
Right. That makes sense. That does make a lot of sense. I got a question. We've talked knees, we've talked hips, we've talked shoulders. What else gets replaced in the body? I mean,
well, there are a lot of. The things the wrist and the ankle are ones, and that's a little more specialized area. I don't do that. That I would say you go to someone who has experience doing that. When I was in training, they weren't doing ankles. That's very, very few places. So that's become more common. There are primarily geared towards people with rheumatoid arthritis. There are small little joint replacements in the hands that sometimes are done.
And similar type materials used, just smaller?
It's a little different in that there have been various. There were silicone ones for a while and metal ones. That's a very specialized area of orthopedics that I haven't dealt with. It's mainly in people who have rheumatoid arthritis.
Gotcha.
In the smaller joints, it's more these in the metacarpophalangeal joints. These, you generally fuse the joint together. But yeah. So as far as in the toe, the big toe, there's a joint replacement because that area that is risk for gout can get arthritis, and some people will.
Gotcha.
So there are some smaller joint replacements, but I would say the ankle and the wrist are the other big ones, and the elbow. The elbow is a lot of that work was done at the Mayo Clinic, just in our neighbor to the west.
That's wonderful. Well, I can't wait to see what we talk about the next time you're on, and I can't believe our time is already up here. I do want to remind everybody we are talking with Dr. Burt Callahan with SSM Health. And, of course, remind everybody to get a hold of you. Numbers ring to the same place, more than likely, but you can call either one, 920-324-6802 or 920-887-6650. Dr. Burt, always amazing having you on. You always bring the coolest stuff for us to look at, and I always feel like I learned so much when you're here. And it really makes me want to take care of my joints because as cool as it would be to say I'm, part metal, maybe you want to hold off on that for as long as I can.
Yeah, I tell people you don't want to meet a guy like me or get to know a guy like me.
Not in this setting. Yeah. This setting's fine, but not in the surgical setting.
I don't want to get to know a guy like me in my professional setting. But
there you go.
So it's always great to be with you, Justin.
Well, I want to thank you for coming on. This has been a paid program. The advice and opinions expressed during the program are solely that of SSM Health, not necessarily WBEV or Good Karma Brands.